Hey, DNA. I'm Kate Wilson, and this is All Access DNA. Today, we are talking about primary care and family medicine. Primary care is often the first stop in healthcare. But where does genetics fit in? Our guests, Dr. Mylanda Massart and genetic counselor Natasha Berman, talked to us about how they integrated genetics into primary care and how this has improved patient outcomes. Let's get started. Hi, Natasha and Melinda. Thank you so much for joining us on the show today.
Thank you
Hi,
for
thanks for
having us.
having us.
I wanted to talk to both of you since you work at the intersection of primary care and genetics, which is an area where we haven't necessarily thought a lot about genetic care. I thought first we could start with trying to figure out why would somebody's primary care doctor talk to them about genetics, or why should somebody ask their primary care doctor about genetics?
So I can start with that one. It's a great question. So I think there are many different pathways to why genetics could come up in a conversation with a primary care physician or provider. Um, and some of the things are that we have really identified are actually strongly in alignment between genetics and primary care, both for preventative care and diagnostics. Traditional things that, family medicine providers do, like prescribing medication, can be heavily impacted by pharmacogenomics. And primary care physicians, especially in family medicine, also provide obstetric care. So one can really think about how carrier screening can come into play before pregnancy, and then actual pregnancy screening during pregnancy, and IPT now beyond the quad screen, helping patients walk through any journeys of CVS or amnio, fertility challenges that they may be going through. And then, of course, newborn screening in the post-delivery phase, which all can have pretty significant genetic relevance. And then, I think we also really think of primary care as the site responsible for screening for cancer. So then we start thinking about hereditary cancer risk assessment and risk stratifying patients to the appropriate level of screening, whether they might be higher risk than the average population. And that's just to name a few. I don't know if, Natasha, you want to add even more?
Yeah, I think primary care is really the place most people are going to start if they have a health concern. So much that we know is that genetics is actually touching most specialties at this point. And so it really makes a lot of sense to have our primary care spaces be genetic aware and genetic ready. I think the other thing is a lot of patients do their own testing and their own investigation, and they're bringing it to their primary care docs. And so we need people to really have a good understanding of at least where to send patients, if not how to deal with it themselves. Because, as we know, most family medicine takes about 70% of every specialty and then knows when to refer. And I think that's actually kind of the ideal thing when we're thinking about genetics. The other piece that I think we need to keep in mind is that oftentimes we think of genetics as a one-stop shop. And that in practice doesn't necessarily work well. Most people who've worked in genetics will remember not terribly long ago when we were like, oh, I guess we have to retest everybody who's had BRCA1 and 2 testing. That's not going to be a one-time thing. We're going to be retesting other people. And so to have primary care have their finger on the pulse of genetics, I think is going to be super essential, because we're going to need to know when patients do need to go back to specialists or not.
And that makes a lot of sense. And so, Natasha, thinking about that kind of one stop, or just you see genetics once and you're done, what you're saying is now that we continue to learn more, maybe find new genes, find new variants, have new technology, there really is not necessarily once in your lifetime genetic testing.
Yeah. Not unless we are planning on like whole genome sequencing everyone. And even then, we would be reanalyzing probably on a regular basis. So,
Right.
genetics
Reinterpreting.
is a lifelong adventure.
And Natasha and I would be totally okay with whole genome sequencing for everyone. But But yes, it would still involve reanalysis. It would still involve advancing our science and understanding. And, we recognize that there are age appropriate and indication appropriate times to analyze. So even if if we got to a single test place, it still requires a lot more support. And I think that brings up another thing about why family medicine or in primary care makes so much sense because, in primary care, we take care of often multi-generational families, and we also take care of patients across the entire lifespan. And so often Natasha and I are really thinking about how can we leverage any genetic testing results across the lifespan of a patient and across the family, right, of the patient to maximize the value. So again, that continuity and the scope of work being that broad is a great place to be able to actually manage and diagnose and treat for various genetic scenarios.
And I think
And
especially the idea of cascade testing is ideal for family medicine, especially if we already have relationships. And many people will end up, not everybody lives in the same place as their family, but many, many people do and will all go to the same, at least clinic.
And Dr. Massart, you had mentioned some good examples of, I guess I'd say, quote unquote, routine testing that a primary care might either be the starting point or performing that have a genetic component or at least a genetic risk assessment needed as part of kind of offering that service. Are there specific genetic tests that you think should be offered in primary care that aren't, like that a primary care doctor should be ordering themselves versus saying, I'm referring somebody on for a mammogram, they'll then assess you for things like hereditary cancer?
Yeah, I think hereditary cancer is a great first place to start just because the guidelines for screening have been out now for quite a long time. And actually the guideline includes, recommendation that we should screen any individual for high risk family history and then test those that meet those criteria. And this is still not happening routinely. Many places have integrated that into their mammogram programs, but mammograms, based on which guidelines individuals are following and institutions are following, may not start well until the 40s. And we know that many of the hereditary cancer conditions need to be screened for and identified much earlier than that to actually have successful high risk screening and catching cancer early and offering treatment or prophylactic treatment to perhaps even prevent those cancers. So I think depending on the mammogram, screening for risk is probably not the most effective way to do it. And really, it should be done as part of routine primary care. And I think, again, understanding family history, understanding past medical history, what's happening is all part of providing that sort of medical home in primary care for patients. And these should be things that the primary care clinics can readily address and integrate and offer patients. If we started referring every single patient that had a genetic scenario arise in their care, we would end up with such a tremendous backlog in the genetics clinics. And we already see that to some extent, right? It's not uncommon for us to hear about a year-long wait list at medical genetics. What I think we really need to be doing is figuring out, and this is really what Natasha and I have spent the last 6, 7, 8 years now working on is, what could be handled by primary care, by PCPs, and what really needs to get triaged and referred up to specialty level medical genetics. And how do we make those distinctions? How do we sort of develop the appropriate algorithms to integrate into primary care and make this easier for patients and PCPs? And then how do we redirect those referrals, just like anything else in primary care when it's really necessary? This actually leads me to like a really important concept that we often talk about, which is, genetics is a specialty and it's a tool. And we have other examples of that in medicine, right? Like radiology. There's radiology that's a specialty, especially interventional radiologists, and radiology is a tool. And In primary care, we order x-rays and MRIs and echoes and, all these things all the time. And then based on the result, we then refer the patient to the right level of care and the right specialist. And I think we need to think about genetics and primary care in that same light, that it's a tool. And then if we get something positive, then we need to, especially if it's something significant, then we need to refer that patient on to a genetic specialist, especially a genetic counselor, and then possibly a medical geneticist to help contribute and manage that condition with the patient and their family. But sending everyone in advance prior to testing and prior to a positive finding would just, again, it would just saturate the system and overload everything.
Yeah,
And
and
I
I
think
think
that makes a lot of sense because again, it's a specialty area, and like you're saying, it's sort of the primary care would be the first stop. Then they can do further evaluation or assessment and then send on to the specialist, right? For that more in-depth discussion, potentially lab work, things like that.
Yeah, for the appropriate things, for the right scenarios, right? So looking at cholesterol profiles and recognizing that that profile is concerning for familial hyperlipidemia, and doing that testing should be well within the scope of family medicine or primary care. And then initiating treatment might even be in scope as well, or referring then on to the genetics cardiology clinic, to the hyperlipidemia clinic for extra specialty management if needed. But something that comes in that is looking more like is going to require deep phenotyping and dysmorphology evaluation, and you're starting to think about what are the right HPO terms for analyzing a WES or a whole genome, that's now getting way beyond the average primary care physician. And those are the types of patients that absolutely need to get referred upfront to medical genetics. And so that's a lot of what we are trying to sort through in our clinic.
And Natasha, I think you were getting ready to say something. I'm sorry, I cut you off.
Yeah, I think, one of the things that we think about and work on is how can we get genetic counselors in a space where they can help with a lot of these things, because even if we know that our family med doctors can order FH testing and familial hyperlipidemia, they may not know the best test or the best way to consent. And while they can definitely learn to do some of those things, I think we can all kind of agree, and there will be a sigh of family medicine physician relief when I say, like, we don't need them to be genetic counselors. We have genetic counselors that can step into those roles and be that like supportive care, not necessarily have to see every single patient, but can help, especially on those like larger scale thought processes in terms of what panel should we be ordering? What does that consent process look like, and how can we be like supportive? And that's part of what happens in a lot of like places now in certain things, right? When we think about like carrier screening and things like that, a lot of the people who are ordering it are obese now, and so can we get everybody to take a little bit, and then also make sure that genetic counselors are there and available to help be the genetic professionals in that family medicine or primary care space.
And I wonder in terms of like working with primary care physicians, because I think about sometimes when I've been to see my primary care physician, and I will disclose that I'm a carrier for like hemochromatosis, things like that. And what I find is that they're very familiar with the condition name, but sometimes when I talk about either further evaluation, or I maybe approach them about doing another genetic test because I'm concerned I may be a carrier for X, Y, or Z, that a lot of times then it's, well, where do, they know I'm a genetic counselor. Where do you think I should send it? What exactly should I order? So what are some of the reasons that primary care physicians have given you for either saying, I don't know if this is something I can offer, or maybe they are interested in being able to work on this, but then they don't know where to send that patient for this more detailed discussion?
Yeah. So I think, one of the biggest things is I think most primary care docs really want to do what's best for their patients. And so I think, and many of them, and we have lots of research studies that indicate they feel like this is something they should be a part of or know. I don't think, Nylinda, you can tell me if you think I'm wrong, but they're already doing 70 of every specialty. I actually don't think that we can given how quickly genetics changes and moves, I just don't think it's reasonable to expect them to also add on genetics with all of its nuances that is it's one kind of confusing. But I do think there are ways that we can give them lots of tools so that we can be getting people to the right places. My Linda and I always call it the easy button. Like we're constantly trying to find the easy button to like insert in the EMR so that there's already language. It pops up and they're like, yes, these are the things I need to say. And this is how I get the patient where they're meant to be.
Yeah, I think, what we were describing is this beautiful ideal state that we think at some point could be achieved. But we know, the barriers to integrating genetics in primary care are large and have in many ways been insurmountable. And so how do we get from this vision where this level of, I'm not sure if I'm still connected. Okay. How do we get from this vision of integrating genetics into primary care to reality and true implementation? And that's going to require some major facilitators. And I think that initially before COVID, we thought perhaps primary care could learn eventually 70% of genetics, just like they learn 70% of endocrinology and nephrology and cardiology and pulmonology. But I think COVID really made it very clear that primary care is maxed out. And
Hmm.
and so I would actually say the top 5 or even the top 10 barriers to actually achieving this is just time, time, and time, and time. And they just don't have the time. And so we are constantly thinking about what could those facilitators look like and what are the different models. And Natasha already mentioned the model that we're really have been exploring heavily the last several years is that historically, primary care has been multidisciplinary. We have had pharmacists, we have had social workers, and
Dietitian.
all, go ahead.
I was going to say also like dietitians, nutritionists.
Nutritionists, yeah, we've had other specialists already working side by side with the PCPs to provide the best care for patients and that genetic counselors, that is not any different. And that one genetic counselor could actually support, multiple number of PCPs by being available for asking questions, by supporting them with these nuanced challenges as an intermediate kind of stage, and really actually to be an on-site educator that helps teach the primary care providers through each of these scenarios. And then we need a lot of other tools. We know we're really entering this era of integrating AI and machine learning into healthcare. And so what does integrated clinical decision support look like? What can that easy button look like to really help guide clinicians through any of these extra challenges when perhaps they don't have access immediately to genetic counseling? And also telemedicine, which has exploded obviously for at first an initial goal in medicine and then really out of need with the pandemic. And it worked so incredibly well for what we do, that we have continued predominantly a telemedicine model in our clinic in primary care. So I think there are a lot of facilitators that we can develop and be creative about to achieve this.
Hmm. And we've talked a lot about like the provider perspective in terms of, how to maybe integrate it or how to add in sort of a workflow for this genetics evaluation referral. How have patients perceived this or what have you in working in this area, how have patients either received having this discussion about genetics or having this genetic testing at least initiated by the primary care doctor?
Yeah, I mean, I think patients overall and overwhelmingly actually do much better coming from the PCP and especially being able to see, we see patients oftentimes in their medical home. And in my experience as a genetic counselor, our patients are so much less anxious because they're already in a space that feels comfortable and safe for them. I think that really helps patients get to genetics. There's so many patients that maybe get a referral and never follow up because of anxiety, logistics, all of these things. So from a patient perspective, I actually think having genetic counselors more easily accessible is essential if we want to have equitable access to genetics care. And I think we get a lot of benefit from that trust that our family medicine providers have because they can say, oh, you're going to go see Natasha and Dr. Messart. You'll love them. They're so great. They're down the hall. It just makes a huge difference in terms of patients' anxiety, their comfort, and if there is follow-up, if they have additional questions, if a year or 2 years later, they're like, I don't remember all of this stuff. They ask their PCP and their PCP is like, oh, great. Just go back to see Natasha. Or like, actually, she's here today. Maybe we'll have her pop in.
Are there any things that you would share with the PCPs, like in terms of like if a patient is concerned about genetic testing or has worries about potentially talking to you, somebody like yourself, Natasha?
I mean, I think the biggest thing is to give them a good idea. And I think our physicians now have a pretty good idea of kind of what they do. I would oftentimes say, they're going to take a family history, they're going to talk through some ideas, and then they're going to make a choice with you, just like we do in our space, right? Most family medicine, most primary care are doing joint decision making. And that's something that genetic counselors are well trained to do. And we know walking in, they can say, you don't have to do tests. We're just having a conversation to make sure we're taking the best care of you and your family that we can.
I actually think that and it being integrated and embedded in the primary care model makes it a little less scary and intimidating. Even when I go to see a specialist, I notice that I'm more anxious and I'm more nervous. It feels different than when I go to see my PCP. And so, and then, it honestly, I don't know at this point, I feel like in our society, people are pretty savvy at this point. And even though they may not know all the details about genetics, they're not fearful. Like it's a pretty common word now. I think direct to consumer testing, ancestry testing has made it kind of a household concept. And so even if they don't have all the details, I don't think it's super far. In fact, I actually think it's more likely that the scenario is that the patient asks their PCP about adding genetics to their care than the PCP recognizing that this might be a genetics relevant scenario and offering it to the patient. I think patients are driving that advancement and expect their PCPs to be knowledgeable in this space.
I think patients can be incredibly savvy in terms of their own research and being able to figure out what's going on and what questions to ask. I've had more than one family who's come in and asked ChatGPT what they should ask me, and ChatGPT had great questions that I was so happy to answer.
Well, it's interesting that you say that because that was sort of my next question. And to Dr. Massart, to your point, yes, a lot of people are going through direct to consumer types of options. What I have learned is that there's a lot of folks that it's not even just ancestry testing, like they have a chronic condition or they feel like they've been dismissed at this point by the medical community. So they're looking for answers. What do you suggest for those patients when they get a result back? Maybe they don't understand something, or maybe they get it and they think they have a condition, but we also know that some of these direct consumer companies are not necessarily as robust in terms of their methodology. So what do you suggest for patients like that who are kind of trying to find out more on their own?
Yeah, and I think that that's been a big part of what we've seen over the last decade is it's moved from this hereditary ancestry testing to actually trying to seek answers for things that they don't have answers for. So more of a diagnostic pursuit that's patient driven and patient led. They do feel frustrated with the healthcare system or let down by the ability of anyone hearing them and recognizing that something is going on. Most of the time, I think that the available direct consumer options out there are still costly and have low value of return. Natasha and I can tell you lots of stories of people sending us pages and pages and pages and pages of SNPs, and it's really meaningless, right? And a lot of the interpretation is proprietary. value is just incredibly low. So we always feel a little bit frustrated for patients when they have paid money and receive this information and then find out from us that it's not really useful. Every once in a while, we get something brought into us that does look suspicious or interesting and aligns with the concerns that the patient is sharing with us. And so then we explain that we need to do clinical testing instead, and either to validate the result that they have or to have a more trustworthy source, laboratory source, and accurate interpretation. And many, many times we find out that really, honestly, genetic testing wasn't the answer anyway to the journey or questions that they had about their health. And again, as primary care, we're able to sort of contextualize that and redirect and really try to understand what is the question, what are they seeking, what are their concerns, and is genetics the right path, or is there a better evidence-based pathway to help guide them through?
Yeah, I think it's one of the great things that we have about that we have working in a primary care space is because we can then do both. We can talk about the limitations of that testing as well as having that PCP work through potentially trying to find a better answer, at least some kind of answer. Dr. Massard and I have had so many patients who have spent just a lot of money on testing like that. I think one of our first ones, I do remember they skipped Christmas so that she could order this testing for herself. And it was just really heartbreaking to find out that like this entire family had decided to do no present so that she could order this testing that they thought they needed because they just weren't getting answers. And the testing that they ordered was never going to answer their question. And it was really heartbreaking. So, I mean, I think especially if patients are interested or seeing something, the first stop should be their primary care who can hopefully get them either their own education by like checking in with somebody or, an ideal world, find one of the genetic counselor. There's a few clinics now that you can do that with. Oh,
Yeah, so I appreciate that story. So Natasha was sharing with us about a patient who unfortunately decided to forego Christmas and some of the presents and things like that in order to purchase a test, only to find out that it really was not very helpful for the answers they were looking for. I think, one of the questions I was going to ask was like patients, how can they avoid feeling overwhelmed by the genetic testing options? But I think that that's sort of the key is talking to the PCP and hopefully the genetic counselor to better understand about genetic testing options and if they truly need genetic testing and which one may be the most appropriate.
yeah, we try to be really transparent within our space about testing and like what it can and cannot do for us. We see a huge amount of connective tissue disorder patients, and we will offer any of them testing as long as they feel that would be beneficial to them. Those that are fitting look like they're going to be very hypermobile, very unlikely that they're going to be a vascular type. Within our own internal research, we have learned that most patients benefit from that from a psychological standpoint. And so it is something that feels very reasonable within our space.
And what I'd like to ask each of you, so I'll start with you, Mylanda, is what do you want people to understand about the future of genetics in everyday healthcare? Because I think for so long it was seen as sort of this genetics is the future of healthcare. Like that's still something we are working towards. But now bringing it into primary care, I think is just another example of how it's really everyday healthcare. What do you hope that folks understand about genetic medicine and genetic health?
I really hope that patients can get excited about how genetic technology and then ultimately genomic technology now even starting to hit the clinical side and multi-omic technology, how just like AI is adding to our toolkit that we can use to hopefully do better and better preventative care and really start shifting the model from sick care, which is really what we currently practice, to true health care, which is the ultimate goal of primary care. And I hope that clinicians can recognize that these tools are valuable and they're available and that we can help support them find these facilitators that allow them to integrate this into their own skill set to varying different degrees. perhaps based on their interest, but that this is truly an option. And I've been thinking about this problem for almost 20 years now. So we are definitely, the train has long left the station. We are not talking about the future anymore. We are talking about catching up and then broadening and growing in these opportunities with technology.
And Natasha, I would ask the same question, kind of like, what do you hope people understand? I would also add in, given that you're a genetic counselor, if there is a PCP or somebody in family medicine that's listening that is interested in figuring out how to integrate more with genetics, where could they start?
I mean, they can email Dr. Massard and I.
I was going to say they should find their Natasha, but
Yeah, they should find. So, I mean, truly, and if there's a genetic counselor listening, my advice is always the same, which is like find your person, and it can start small. What we have experienced is that the need is very much there, and so you could start small with like a half day a week, but within a year, at least in our experience, all of a sudden you have two full-time genetic counselors working in family medicine. And it's one of those things where once you sort of have that experience, you're like, oh no, this was always meant to be part of my team. And so to any primary care clinicians or administrators out there, you know, this is, I think, the way of the future that we have to do. And for patients, I would say don't be afraid to ask and advocate for yourselves. One of the things that I think we are giving to patients, especially in our setting, is we are spending a lot of time doing like education, helping them ask questions and getting that full genetic counselor experience, which I think really helps patients feel more comfortable doing some of that self-advocacy. And so even if you haven't seen a genetic counselor yet, I hope that they are able to do some of that advocacy to say, I need to see a genetics person, help me. And, I would be shocked if not virtually every single primary care doctor is like willing to see what they can't do. Because again, in my experience, they want to help. They just don't always have all of the tools, but they're out there. But, once one patient starts asking, we see a domino effect. We're like, oh, this is like one patient, and then we're like, now there's 3, now there's 5. Once they're in that process of knowing where to send people, they're on it.
Mm-hmm.
And I would add that it's not just that, it's that once you start opening your eyes up to the genetic scenarios that are actually playing out in primary care every single day, you will start to see that each individual has more than one, right? One of the amazing tools that I think our genetic counselors created in the clinic is this primary care approach to taking a pedigree and we've been tracking, what's the primary reason that we're seeing the patient that they were sent to see us, and then how many secondary, tertiary, and even, fourth indications that we have found in one conversation with a patient. And that's not uncommon. And again, that's because in primary care, everyone is there. Everyone is in primary care, and all patients, all families, all different types of wellness and disease and family histories. And so if you start asking the questions and you're looking for the genetic relevance, it's there in abundance.
Yeah, I think when we've looked at that data, I think, Dr. Massart, we were averaging at least one secondary indication per day in a time when we were seeing maybe like a day and a half of patients. So, I mean, it's, I think, very rare for us to see a patient and only talk about one thing.
Mm-hmm, mm-hmm. And that makes sense too. And I think with, again, as we learn more, there's more options out there um, in terms of not just like testing, but understanding the genetic role of certain conditions, that there's going to be multiple things probably in a family that at least need some sort of assessment or evaluation. What I'll do is I will put a link in the show notes to like the Find a Genetic Counselor tool just for folks that are looking for their Natasha. And if there's any other helpful resources that you both have that you think would be good, we can add those in as well. But before we wrap up, is there anything that we didn't cover or anything that you hope that listeners take away from the conversation?
I mean, I personally just want to add that, in the way that our healthcare is set up currently with fee for service. We strongly need to advocate for genetic counselors to be recognized as clinicians, as providers, and to be able to independently bill and be compensated for their skill set and their time. And if that happens, then the feasibility of integrating genetic counselors as multidisciplinary colleagues and partners into the primary care setting will become more and more available to us. Currently pharmacists bill, nutritionists bill, social workers and psychologists bill, and that's what makes that a sustainable model. And we need to be looking at the same to support genetics.
Well said. Natasha, anything for you?
I mean, I don't can follow that up. I promise I didn't tell her to say that ahead of time, but certainly I agree. We need to find a way to get we need to find a way to get the genetics professionals where the patients are. So and I hope that patients, if they take anything away, I think it's if they have a question about genetics, ask. And even if their PCP doesn't know, ask them to find somebody who can answer.
Mhm. Yeah, I think that it, again, there's no harm in asking, and then I think the other piece is we will definitely see a sea change once genetic counselors are recognized by Medicare and are able to be reimbursed. So I'm glad that you put that in, Dr.
Put that in
Mouser,
the
as
show
well.
notes in case
Yes,
put
we
that in
will
the
put
show
that
notes if anybody
information.
wants to write their representatives.
Yes,
Yes, that's what
exactly.
I'm saying. Everyone needs to lobby for this and support it. But I agree. You might be the very first patient to ask your PCP a genetics question, but someone has to be the first one. And so they might not have the answer. Don't be mad at them. They weren't taught. And instead encourage them. Say, I hear that family medicine and primary care are starting to do this, and there are resources, and I promise you will light a fire, and they will investigate, and you will be helping all future patients for that clinician.
Definitely. Well, thank you both so much for taking time to talk about it. I'm excited that there is this discussion and that there are folks like yourselves that are integrating this genetic medicine into the primary care setting. Because again, the PCPs tend to be at the front lines of a lot of taking care of individuals and families. So thank you both for being here.
Thank you.
Thank you.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all episodes of the show. This link is also in the show notes for easy access. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Check out our Patreon at patreon.com/allaccessdna and consider donating to get bonus content, submit questions for our guests, and connect with other genetic curious individuals. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. Please rate and review the podcast on Apple, Spotify, or wherever you listen. This helps other people like you discover the show. All Access DNA is hosted, produced, and edited by Kate Wilson. The logo design is by Designs by NKJ. Thanks for listening, and join us next time.